Welcome back to the deep dive. Today we are stripping away the fluff.
We really are. We're getting straight to business.
Yeah, this is a high-yield revision session. It's designed specifically for you residents who are staring down the barrel of your plastic surgery board exams.
Right, whether you're prepping for the FRCS or your local equivalent.
Exactly. And today we are tackling the external ear.
It's one of those topics that feels approachable until you actually have to draw it.
Oh, absolutely.
Or, explain a reconstruction plan under pressure to an examiner.
Yeah.
I mean, it ranges from the deceptive simplicity of embryology right through to the intense technical nuances of the Nagata reconstruction.
It's a huge topic. And before we dive into that anatomy, just a quick heads up for you listening.
Hi.
If you are using this series to prep for your exams, hit that follow button right now.
So you don't miss the upcoming modules.
Right. And if you learn something new in the next 15 minutes, please leave us a rating. It really helps other residents find the material.
And leave a comment if there is a specific topic you are struggling with. We read them, and we build these deep dives based on what you need.
We do. Now, we also need to be clear about the scope here today.
Yes. We are going to cover the core theory and the textbook answers you need. But as we all know, the oral component of the exam.
The Viva.
Exactly, the Viva. That is about clinical judgment. You need to hear how this theory is applied to actual patients.
And for that, you need our Journal Club and Clinical Cases episodes.
Which are locked behind the premium subscription.
That is where the real exam technique is sharpened. So consider this the essential theory and the premium content, the clinical application.
If you're serious about passing, go to the website and get the premium tier.
All right, let's get into it. We really can't talk about fixing the ear without understanding how it's built.
No, you can't.
So we have to start with the embryology.
It is the foundation for everything else. The timeline is the very first thing you need to lock in. The external ear, or auricle, starts forming surprisingly early. We're talking during the 5th week of gestation.
5th week.
The fundamental process is the ectoderm inducing the underlying mesoderm to differentiate into cartilage.
Okay.
And by the 6th week, we see those famous hillocks appearing.
The hillocks of his, this is bread and butter anatomy, but there's a nuance here that catches people out. There are 6 hillocks in total.
Correct.
Walk us through where they come from.
They originate from the branchial arches. You have the first branchial arch, which gives us the anterior 3 hillocks.
Okay.
And the second branchial arch, which gives us the posterior 3.
And what's between them?
Between those two arches sits the first branchial cleft, which is destined to become the external auditory meatus.
Now, historically, textbooks had these neat little diagrams showing exactly which hillock becomes which part of the adult ear.
Oh yeah, the jigsaw puzzle.
Right, like hillock 1 is the tragus, hillock 6 is the lobule, and so on. Is that still the answer the examiners want?
That is the trap. The old jigsaw puzzle theory is largely considered outdated now.
Good to know.
If you stick too rigidly to that in an exam, you might get pulled up on it. The current understanding is that these hillocks actually blend into a bland mass before the recognizable auricle forms.
A bland mass.
Yes, it is not a direct one-to-one mapping for every single structure. However, for the sake of the boards, we do need to know the broad derivations from that mass.
Right, so we look at it in terms of the arches. What generally comes from the first arch versus the second?
Well, the ventral part of that mass, which comes from the first arch, gives us the anterior structures. That's the tragus, the antitragus, the lobule, and the helical root.
Okay, ventral is first arch.
Then the dorsal part from the second arch forms the bulk of the rest. So the concha, the triangular fossa, the inferior crus, and the body of the antihelix.
And what about the helix itself? That seems to be the outlier.
It is. Most of the helix, along with the scaphoid fossa and the superior crus of the antihelix, actually derive from the free ear fold.
The free ear fold.
Yes, this is a separate area entirely, just posterior to the helix of the second arch. It's a bit more complex than just saying 6 bumps become an ear.
Right.
By the 9th week, though, you do have a recognizable auricle.
Let's shift to the sensory nerve supply. This is a classic Viva question.
Draw the map.
Exactly, draw the map. You have 4 nerves supplying the ear. How do you break this down mentally?
I like to divide the ear into quadrants or zones. The big one is the great auricular nerve.
The workhorse.
Right. It supplies the inferior half of the ear, covering both the lateral and medial aspects. That is your workhorse nerve for blocks.
And moving up.
Then, moving up, the lesser occipital nerve supplies the medial aspect of the superior half. So the back of the top of the
Like
ear.
the front of the top.
That is the auriculotemporal nerve. It handles the lateral aspect of the superior half.
That leaves the fourth one, which is probably the most clinically relevant one when things go wrong in the office.
Arnold's nerve. This is the auricular branch of the vagus nerve. It supplies the concha, the deep bowl, and the external auditory meatus.
And why do we flag this one specifically for the residents?
Because of the vagal reflex.
Yeah.
It's remarkably common. You are cleaning a patient's ear or maybe placing a tight pack in the canal, and suddenly they start coughing uncontrollably.
Or feeling nauseous.
Exactly. That is Arnold's nerve being stimulated. It's a very specific anatomical correlate that examiners love because it explains a physiological reaction.
It is a really good reminder to be gentle in the concha. Briefly, what about the blood supply?
It's incredibly robust, which is the only reason we can get away with some of the flaps we do.
True.
It is supplied by branches of the external carotid, specifically the posterior auricular, the superficial temporal, and the occipital arteries.
And the main takeaway for the exam?
The extensive collateralization between all three systems. That network is what keeps our reconstructive flaps alive.
Moving on to Section 2, congenital deformities. The big topic here is microtia. We usually use Tanser's classification. Can you give us the rapid rundown of the groups?
Sure. Cancer group 1 is anotia.
Complete absence.
Right, complete absence of the ear. Group 2 is microtia, essentially a miniature malformed ear. This one is subdivided. Type A has atresia of the canal, and type B does not.
Okay, group 3.
Group 3 is hypoplasia of the middle third. Group 4 involves the superior third, which covers things like constricted ears and cryptotia. And finally, Group V is prominent ears.
Let's focus on the epidemiology of microtia. It is not distributed evenly across the globe, is it?
Not at all. In the Western world, the incidence is roughly 1 in 6,000 births.
Okay.
But if you look at Japan, it jumps to 1 in 4,000.
Mm.
And among the Navajo population, it is remarkably high, around 1 in 1,000.
And there are some specific ratios regarding gender and laterality that seem to come up in multiple choice questions all the time.
Yes, the rule of right and male. There is a male predominance about 2.5 to 1.
And the laterality?
Crucially, it affects the right side much more often than the left. The ratio is roughly 6 to 3 to 1, so that's right side, left side, bilateral.
Now, a huge concern for parents is hearing. They see a malformed ear and immediately assume the child is deaf on that side.
Naturally.
What is the embryological basis for explaining the hearing status to a parent?
This goes back to our timeline. The inner ear develops from the otic placode, which invaginates separately.
So it's completely separate.
Exactly. It doesn't come from the branchial arches. Because microtia is a branchial arch anomaly, the inner ear is usually spared. So the child typically has functional sensorineural hearing.
But the conduction is the problem.
Exactly. The middle ear and the eustachian tube come from the first pharyngeal pouch. Since the arches are messed up, the pouch structures usually are too.
Right.
The ossicles are often fused or malformed, and there's often no canal. So they have conductive hearing loss.
And how do we manage that in the early years?
You have to be aggressive with bone conduction hearing aids. This is vital, especially in bilateral cases, to ensure speech acquisition isn't delayed.
Do we open the canal?
We generally avoid trying to surgically open the canal at tresioplasty because the risk of damaging the facial nerve or the inner ear is high. Plus, the hearing gain is often prone to restenosis anyway. Bone-anchored hearing aids are usually the better path.
Before we get to the surgery, we have to mention syndromes. If a child walks in with microsonia, what else are you checking?
You have to look at the whole face. Treacher-Collins is the famous one involving bilateral hypoplasia, but hemifacial microsomia is the most common association.
How common?
Somewhere between a third and a half of microsomia, patients have some degree of hemifacial microsomia. You need to look for mandibular hypoplasia, soft tissue deficiency, and even issues with the facial nerve.
All right, let's get to the heavy lifting. Section 3, Reconstruction. This is where the board exam tests your planning. You are building an ear from scratch. Where do you put it?
You can't just guess. You need 4 key alignment points to make it look symmetrical.
Let's list them.
First, the vertical position. The top of the helix should match the arch of the eyebrow. Second, the lobe. It should sit at the level of the nasal tip. Third, the helical root. This aligns with the lateral canthus of the eye.
And the fourth point?
That is the axis and height. The distance from the lateral orbital margin to the helical attachment should be roughly 1 ear height.
Which is how much?
A standard ear is about 65 to 70 millimeters tall, so that gives you your spacing from the eye.
We generally have 3 main avenues for reconstruction: prosthetic, autologous, and alloplastic. Let's start with prosthetics. This isn't just gluing on an ear.
No, the gold standard here is osseointegration, pioneered by Braunmark. It involves placing titanium fixtures into the mastoid bone.
Right.
These are often coated with titanium oxide or calcium hydroxyapatite to bond with the bone. It used to be strictly 2 stages: put the screws in, bury them, wait for bone growth, then uncover them. Now, single-stage placement is much more common.
It sounds like an easy out, but there are downsides.
Huge downsides. Infection is a constant risk around the abutments. There is the daily maintenance. But the biggest one is psychological. Patients often report that it feels like an accessory rather than a part of their body. It comes off at night. That can be deeply traumatic for a child.
Which brings us to autologous reconstruction using rib cartilage. This is the true plastic surgery approach. We have 2 main titans in this field you need to know: Brent and Nagata.
This comparison is very high yield.
Let's start with the timing differences.
The timing is dictated by the rib cage. The ear reaches 85% of its adult size by age 4. But we can't operate that early because the ribs aren't big enough to carve a framework.
So where do we go in?
For the Brent technique, we usually wait until age 6. For Nagata, the framework is much more substantial. It requires more cartilage. So we generally have to wait until the child is older, maybe 9 or 10, to get that bulk.
Walk us through the Brent technique. It is older, but it is definitely still tested.
Brent is a 4-stage process, and you have to wait at least 3 months between stages to let the blood supply recover. Stage 1 is the big one: fabrication and insertion of the framework. A key detail here is that Brent harvests cartilage from the contralateral chest to get the natural curvature of the rib to match the ear. He places it in a pocket under virgin, unscarred skin.
Stage 2.
Stage 2 is lobule rotation, moving the earlobe into position.
Stage 3.
Stage 3 is elevation, lifting the ear off the head and skin grafting the back.
And the final stage.
Stage 4 is the tragus reconstruction, often using a composite graft from the other ear.
It is a marathon. 4 surgeries. How does Nagata change the game?
Nagata condenses this into 2 stages, but each stage is significantly more complex.
Okay, stage 1 for Nagata.
Stage 1 is the workhorse. He constructs a very detailed framework with a base plate and mounts the helix, antihelix, and tragus components onto it. He uses stainless steel wire sutures to hold it all together.
So it builds the whole thing?
Yes, he inserts this and transposes the logule in the same operation.
So you get most of the ear in one go?
Correct. Then stage 2, about 6 months later, involves elevating the ear. He uses a cartilage wedge to maintain the projection, and, this is the critical difference, he covers that elevated fascia and wedge with a temporoparietal fascial flap, or TPF, and a split skin graft.
So Brent relies on the skin pocket, Nagata relies on a more complex framework, and eventually a flap for elevation.
Precisely.
What about the third option? Alloplastic. Medpore.
This uses porous polyethylene. You don't need to harvest rib, which saves the chest scar and the pain. You can buy a shape or carve a block.
But there's a catch.
The historical problem was that these are foreign bodies, and the extrusion rate was terribly high. The body just pushed it out.
How do they make it work now?
The TPF flap. You absolutely must cover the Medpore implant with a vascularized temporoparietal fascial flap before putting the skin graft on. That living layer acts as a buffer and brings blood supply to the area, drastically reducing the extrusion risk.
Let's shift gears to section 4, otoplasty in prominent ears. This is a very common procedure, but it requires analysis. What actually defines a prominent ear?
It is largely subjective. I mean, if the patient thinks they stick out, they stick out. But for the exam, you need numbers.
Give us the numbers.
We look for a helix-mastoid distance of more than 2 centimeters and a pinna-to-mastoid angle of greater than 25 degrees.
And mechanically, why are they sticking out? It is rarely just one thing.
Right, you have to diagnose the cause. It is usually a triad. 1, chondral hypertrophy, the bowl is too deep, pushing the whole ear away from the head.
Right.
2, absence of the antihelical fold, the ear's unfurled and flat. Or 3, a mixed picture, which is honestly the most common presentation.
When do you operate? Parents often want it done as toddlers.
You have to push back on that. We avoid it before age 4 because of the risk of growth disturbance.
Right.
But the real driver is social. Teasing usually starts when school gets serious, around age 7 to 10. That is the common window. But we have a hard rule. Never operate solely for the parents. If the child is happy and resisting surgery, you wait. You need the patient on board for the recovery.
There is a tiny window for non-surgical management, though, right?
Yes, the golden period. The first 3 months of life. Maternal estrogens are still circulating in the baby's system, making the cartilage soft and malleable.
So you can mold it.
Exactly. You can use splinting or molding devices during this period with excellent results. Once those estrogens drop, the cartilage hardens and the window closes.
Let's talk technique. For the boards, you need to know your eponyms for the sutures.
There are 3 main suture techniques you absolutely must be able to cite.
Number 1.
First, furnace sutures. These are conchomastoid sutures. They go from the conchal cartilage to the mastoid fascia. They essentially pull the bowl closer to the head to treat conchal hypertrophy.
Number 2.
Second, Mustardase sutures. These are mattress sutures placed on the posterior surface to create the antihelical fold. You tighten them to curl the ear.
And the third.
Third, fossa fascia sutures. These connect the scaphoid fossa to the temporal fascia to correct upper pole prominence.
And we use permanent sutures for these.
Yes, typically permanent monofilament like nylon or Prolene. You are relying on the suture strength to hold the memory of the cartilage in the new position.
Sometimes sutures aren't enough. You have to break the spring of the cartilage. What is the governing principle here?
Gibson's principle. It is a key concept. It states that cartilage will bend away from the scored surface. So if you want the ear to fold backward, you need to score or weaken the anterior surface.
And the named techniques for this?
Zhangchet described anterior scoring via an open posterior approach. So you access the anterior cartilage from behind, essentially degloving parts of the ear.
Yeah, and the other one.
Stenstrom described a closed technique, where you introduce a rasp via small incisions to score the anterior surface without fully opening the skin.
Okay, we are in the home stretch. Let's do a rapid-fire review of other auricular deformities. I will give you the name, you explain the pathology.
Let's do it.
First, the constricted ear.
This is a spectrum deformity. At the mild end, you have lop ear, which is just a downward folding of the superior helix. At the severe end, you have cup ear, which is a lop ear plus prominence. Fundamentally, it is a deficiency in the circumference of the helix, like a drawstring bag that's been pulled too tight.
Next, stall ear.
The Spock ear. It looks pointed. The cause is an abnormal third crust traversing the superior third of the ear, specifically crossing the scaphoid fossa. It flattens the helix and creates that point.
Cryptotia.
The hidden ear. The upper pole of the helix is buried under the temporal skin. It is not that the cartilage is missing, it is just submerged.
And demographics for this.
This is rare in Caucasians, but quite common in Asian populations, particularly in Japan, where it's about 1 in 400. The insight here is that there is a skin shortage, so you need local flaps to release it.
Finally, the telephone ear.
This is usually an iatrogenic disaster, meaning we caused it. It is an acquired deformity post-otoplasty. It happens when you overcorrect the middle third of the ear with your sutures, but fail to address the upper and lower poles. The middle is pinned tight, the top and bottom stick out, and it looks exactly like an old-fashioned telephone handset.
And that leads us perfectly into our synthesis. We've covered the hierarchy. Molding comes first if they are infants. Then, if surgery is needed, you determine if tissue is missing, that is microsutia, or if it's just misshapen, which is your prominent or constricted ear.
Precisely. And that telephone deformity provides the final provocative thought for this session.
How so?
It serves as a warning about tension. When you are placing those mustardae or furnace sutures, you are dealing with vectors. If you tighten one area too much without respecting the others, you distort the entire 3D structure. Otoplasty isn't just pinning back, it is about balancing tension.
A vital reminder that correcting one vector can distort another. Well, that covers the theory. But listen, in the exam, they aren't just going to ask you to list the furnace suture.
No, they are going to show you a picture of a child with hemifacial microsomia and ask you to talk through your management plan for the next 10 years.
Exactly. You cannot learn that kind of clinical judgment from a list of facts. You need to hear the decision-making process.
We cover that extensively in the clinical cases episodes.
So go to the website. Buy the premium subscription. It unlocks the clinical cases and the journal club. That is where you bridge the gap between knowing the anatomy and actually passing the board exam.
Don't leave it to chance.
Keep studying. We will see you in the next deep dive.